acute cholecystitis. So there's some guidelines regarding to the acute cholecystitis, which are the Tokyo guideline, which classify the acute cholecystitis into three grades: mild, moderate, and severe. And the treatment plan depends upon the grade. So first, let's discuss the grading according to the Tokyo guidelines. Tokyo guideline for acute cholecystitis. So first we have the grade 1. But before discussing the grade 1, let's discuss grade 2 and grade 3. So what is grade 2? It is presence of one or more of the following: elevated WBC count, which is more than 18,000, right? Palpable tender right upper quadrant mass. Then you have the duration of complaints more than 72 hours. Then you have marked local inflammation, which may be present in the following forms: biliary peritonitis, right? Hepatic abscess, gangrenous cholecystitis, then emphysematous cholecystitis, and you have pericholecystic abscess. So if you are given in clinical scenarios where it is mentioned gangrenous cholecystitis or biliary peritonitis, it would be a grade 2 according to the Tokyo guideline, right? Then what is grade 3? So grade 3 is presence of one or more of the following. So in the central nervous system you have decreased level of consciousness. And then in the cardiovascular system you have hypotension, right, and requiring the dopamine support, which is at more than 5 microgram per kg per minute, or requiring dobutamine. And then have your respiratory parameters, where the PaO2 and FiO2 ratio is less than 300. Then we have renal parameters, where serum creatinine is more than 2 gram per deciliter. Liver, where INR is more than 1.5. And last is the hematological, where your platelet counts are less than 1 lakh. So I had left behind the discussion of the grade 1. So what is grade 1? That does not meet the criteria of either grade 2 or grade 3. That does not meet criteria for grade 2 or grade 3, and there is no organ dysfunction in it, and it's mild gallbladder inflammation only. So how does this Tokyo guideline help us to treat our patient? So, if it is a grade 1 patient, we can go for early lap cholecystectomy. Initially, this word early was limited to 48 to 72 hours. However, if the patient presents, they may be operated even at the duration of 5 to 7 days, depending upon the experience of surgeon. Right? In case of grade 2, you have to give some antibiotics and supportive care, right? Followed by lap cholecystectomy. So this could be either early or this could be either late. Also, if you have to do some urgent treatment over here, considering the hemodynamic status of the patient, since the patient is presenting GB perforation or an abscess over there, you just basically just do an urgent or an early GB drainage, and the definitive treatment shall be taken later. Now, in case of grade 3, what do we do? So, over here we give antibiotics and supportive care, and then we see whether there is any organ failure or negative predictive factor, right? So we assess for any organ failure, right? If the answer is no and patient is having good performance status, right, in such cases early lap chole may be taken, right? But usually over here, if the in grade 3 they will usually present with organ failure, right? So over here what we do is an urgent or an early GB drainage, right? Following by which, if the patient has a poor performance status, we basically just observe the patient, and if has a good performance status, then in this cases we can go for a delayed lap chole. So having discussed about lap chole, always remember that standard for gallstone disease is laparoscopic cholecystectomy. Almost all centers have switched over from open surgery to laparoscopic surgery in case of cholecystectomy. So let's take a look at your acute cholecystitis. Right. So we have this Tokyo guideline. We have grade 1, which does not meet the criteria of grade 2 or grade 3. Grade 2 is WBC count more than 18,000, palpable tender right upper quadrant mass, duration of complaint more than 72 hours, marked local inflammation. Grade 3, presence of one or more of the following: CNS, level of consciousness is decreased, CVS, hypotension requiring dopamine support, respiratory, that is PA to FI2 less than 300, renal, serum creatinine is more than 2, liver, INR is more than 1.5, and hematological platelet count are less than 1 lakh. So in grade 1, you can go for early lap chole. Grade 2, antibiotics and supportive care. So depending upon the presentation of the patient, you can go for a lap chole, which would be early or late. And if there is an abscess or some abscess or marked inflammation where you think that there's urgent drainage required of the gallbladder, so you do an urgent drainage and then defer the cholecystectomy for a later duration. Now, grade 3 is antibiotics and supportive care as mandatory thing. Then you assess for the organ failure, right? If there is no and the good performance status, you can actually perform an early lap chole. With the bad performance status, you only perform the drainage, right? Bad, perform an early GB drainage. So after early GB drainage, you find that there's a good performance status, you can go for a delayed lap chole, and poor performance status, you can just observe the patient. The standard for gallstone disease is laparoscopic cholecystectomy. Now, what you need to remember over here, mainly in Tokyo guidelines, is the criteria of Tokyo guideline and the plan of treatment. In type 3, where the patient is hemodynamic stable, you would obviously not take immediately the patient to the operation theater. Over there, antibiotic becomes mandatory. In case of grade 2, you need to give some antibiotics and supportive care before shifting the patient for early or delayed lap cholecystectomy, which would be basically depending upon the scenarios and the clinical conditions that are presented to you in the questions.